Dear students, the third presentation in pharmacotherapy of congestive heart failure. Here I am going to explain the drugs which provide symptomatic benefits. Inotropic agents, digoxin, dopamine, dobutamine, diuretics, furosemide, which is a high ceiling diuretic, spironolactone, which is a potassium sparing diuretic, vasodilators including nitrates which dilate the veins, hydralazine, an arteriolar dilator, sodium nitroprusside which dilates the veins and arteries equally. Inodilators means drugs which produce both inotropic effect and vasodilatory effect, Inamrinone, Milrinone, Levosimendan. Ivabradine is a pure bradycardia producing drug. Nesiritide is a recombinant brain natriuretic peptide. Tolvaptan is a Vasopressin receptor antagonist. I am going to explain these two special combinations of drugs which are used in heart failure. These two combinations provide not only symptomatic but also survival benefit. We'll start with the inotropic agents, digoxin, dopamine, dobutamine. First of all, digoxin, a cardiac glycoside. Glycosides, like alkaloids, are obtained from nature. Digoxin has a positive inotropic action on the myocardium. That means digoxin increases the myocardial contractility in a dose-related fashion. This it does so by inhibiting a myocardial enzyme known as sodium potassium ATPase. This enhances intracellular sodium concentration, which increases intracellular calcium concentration, which in turn increases myocardial contractility. Digoxin improves myocardial efficiency. Let us see how. Digoxin, along with increasing myocardial contractility, also reduces heart rate at therapeutic doses by a direct action, a vagomimetic action, and an anti-adrenergic action. Because the heart rate is reduced, the oxygen requirement will not increase. This is we have to compare digoxin with other agents like adrenaline and noradrenaline, which also increase myocardial contractility, but they reduce myocardial efficiency because they increase the heart rate and the oxygen requirement increases. Now, what is the role of digoxin in the treatment of heart failure? Digoxin was a very important drug which was invariably used for all patients of heart failure till the 1970s. But now we have other drugs like ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, which are preferred ahead of digoxin because these group of drugs provide not only symptomatic but also survival benefits. Now let us see, digoxin produces only the benefit in decompensated or symptomatic patients. That means I have to use digoxin in a patient of heart failure only if the patient is symptomatic, that is he is decompensated, that is he may require hospitalization, only till the symptoms subside. Once the symptoms subsides, I will remove digoxin from the treatment in that patient because digoxin does not provide any survival benefit or prognostic benefit. Digoxin will not interfere with the progression of heart failure. This is because digoxin does not antagonize the neurohumoral perpetrators of heart failure like sympathetic overactivity, like overactivity of the renin-angiotensin-aldosterone system. Now, whenever I use digoxin in symptomatic patients, therapeutic drug monitoring is needed because digoxin is a drug with low therapeutic index. That means whenever we use digoxin in patients of heart failure, you should always expect toxicities of digoxin. Digoxin can cause extracardiac and cardiac toxicities. So GIT and CNS toxicities are not serious. Anorexia, nausea, vomiting, abdominal pain, mental confusion, visual disturbances, they are not serious. They do not require any intervention. Whereas cardiac toxicities are very serious because they can cause mortality. So interventions are required for cardiac toxicities. Tachyarrhythmias and bradyarrhythmias are the cardiac toxicities of digoxin. That means tachyarrhythmias, there is an increase in the heart rate. Bradyarrhythmias, that means there is a reduction in the heart rate. Now, what is the reason for tachyarrhythmias? It is because of enhanced ectopic automaticity in the Purkinje fibers. That means the ectopic pacemakers become very active. So what we see in the action potential of the Purkinje fibers is there is an increase in the slope of phase 4 depolarization of the Purkinje fibers. That enhances the automaticity that is responsible for tachyarrhythmias. In fact, all varieties of arrhythmias are observed in digoxin toxicity. Pulsus bigeminus, nodal extrasystoles, ventricular extrasystoles, ventricular tachycardia, ventricular fibrillation, atrial flutter, atrial fibrillation. These are all the arrhythmias which can be seen in digoxin toxicity. So how do we manage these cardiac toxicities? Suppose the arrhythmias are due to chronic administration of digoxin, I have to administer potassium chloride because potassium reduces the interaction between digoxin and the enzyme sodium potassium ATPase, reducing the toxicity. Lignocaine may be used to terminate ventricular arrhythmias, and propranolol is used to overcome atrial arrhythmias. Propranolol reduces the conduction in the AV node, so the impulses from the atria will not reach the ventricles. Bradyarrhythmias are seen in digoxin toxicity because digoxin reduces the conduction of impulses in the AV node. So we can see a partial or a complete AV block. So how to overcome this? A temporary pacemaker can be inserted or atropine may also be used. A word of caution here, excessive potassium can precipitate AV block. So whenever I use potassium chloride to treat digoxin toxicity, I have to measure the levels of potassium first. And lignocaine is preferred over drugs like quinidine, procainamide, propafenone for ventricular arrhythmias in digoxin toxicity because lignocaine does not exacerbate AV block. Now, digoxin antibodies are also available for the treatment of digoxin overdose or digoxin toxicity. In fact, this antibody has improved the prognosis in patients who are diagnosed with digoxin toxicity. These antibodies enhance the renal excretion of digoxin after binding to them. Now, allergic reactions are not seen with the digoxin antibodies because they do not contain the FC portion. Now, the take-home message with digoxin is used only for symptomatic cases of heart failure because it does not provide any prognostic or survival benefit. However, we can use digoxin for a long time in patients where heart failure is due to atrial fibrillation, and it can also be used for the treatment of chronic atrial fibrillation. For acute atrial fibrillation, beta blockers and calcium channel blockers, which are non-dihydropyridine like verapamil and diltiazem, are used. So what you see is the plant from which the cardiac glycosides are obtained. This belongs to the family of digitalis. Digoxin is obtained from the species called as Digitalis lanata. The oral formulation of digoxin, where it is available as a 125 microgram tablet. Digoxin has a half-life of 40 hours. The daily maintenance dose is 125 to 500 micrograms. The full therapeutic benefit or the maximum therapeutic benefit of digoxin is seen after 4 half-lives when digoxin attains what is known as steady state plasma concentration or steady state serum concentration. The therapeutic concentration of digoxin in the plasma is 0.5 to 1.4 nanogram per ml, and the toxic concentration of digoxin is greater than 2 nanogram per ml. The other two inotropic agents, dopamine and dobutamine, are used because they have a beta-1 agonistic activity. Henceforth, cardiac output is increased, giving rise to symptomatic benefit. However, there are no survival benefits. Dopamine and dobutamine are used to overcome emergency pump failure, that is acute decompensation. And these drugs are used to provide additional hemodynamic benefit over and above that produced by the combination of digoxin, furosemide and nitroprusside. Digoxin, an inotropic agent; furosemide, high ceiling diuretic; sodium nitroprusside, arteriolar and venodilator. Dobutamine injectable dopamine. Now, diuretics in heart failure. So after inotropic agents, we discuss furosemide and spironolactone. Furosemide is a high ceiling diuretic which is indicated in highly symptomatic patients. Diuresis produces a reduction in edema which provides a symptomatic benefit. And in fact, intravenous furosemide in left ventricular failure provides symptomatic benefit even before diuresis because it increases venous capacitance. However, furosemide does not produce any prognostic benefit, no survival benefit, hence only used for symptomatic patients. Should never be indicated in asymptomatic patients. And when I use furosemide for a long time, I can see resistance in the patient towards furosemide, and I can overcome that resistance by adding spironolactone. Furosemide injectable and furosemide tablets. Spironolactone tablets. Number 3, vasodilators in heart failure. So we have venodilators, that is nitrates, arterial dilators, hydralazine, veno and arteriolar dilators, sodium nitroprusside. Vasodilators are basically used in acute heart failure that occurs episodically in advanced cases or in those patients following an episode of myocardial infarction. They are used only short term to tide over the crisis in acute heart failure patients. Glyceryl trinitrate is indicated in acute left ventricular failure following myocardial infarction because, being a venodilator, it reduces the venous return. The end diastolic filling, the ventricular filling, is reduced, giving rise to a symptomatic benefit in patients of acute left ventricular failure. Hydralazine, being an arteriolar dilator, reduces peripheral resistance, is indicated in forward failure patients with reduced cardiac index. Sodium nitroprusside produces both arteriolar and venodilatation equally, and it is used in acute decompensated heart failure patients along with furosemide and digoxin. Now, the standard treatment for severe decompensated heart failure patients is a combination of an inotropic agent, a high ceiling diuretic and a vasodilator, digoxin, furosemide and sodium nitroprusside. This is the conventional treatment. This is the standard treatment for severe symptomatic heart failure patients. Now, coming to inodilators. So as the name suggests, these drugs produce both inotropic effect as well as vasodilatation. Inamrinone and Milrinone are phosphodiesterase 3 inhibitors. Cyclic AMP is a substrate for this enzyme, because of which it accumulates in the myocardium and blood vessels, giving rise to inotropic effect in the myocardium and vasodilatation, both arteriolar and venodilatation. Hence, a symptomatic benefit is seen because of improved perfusion and because of reduced load on the heart. So These two drugs are indicated in refractory cases of severe decompensated heart failure. That means when a patient is having acute decompensation, when the patient is highly symptomatic, as I told you, I am going to use the standard drugs, that is digoxin, then furosemide, sodium nitroprusside. In case I don't get the required benefit from this combination, then I can add the inodilators to provide symptomatic benefit over and above the combination which is regularly used. Levosimendan, in addition to inhibiting phosphodiesterase 3, sensitizes troponin C to calcium. It also opens the voltage sensitive potassium channels in the blood vessels, giving rise to vasodilatation and inotropic action, and in the process provides symptomatic benefit. So please remember, all these drugs, they provide only symptomatic benefit. Again, like the previous two drugs, it is also indicated as an add-on in severe refractory decompensated patients. Amrinone injection. This is a Milrinone injection. The injectable levosimendan. Now coming to Nesiritide, which is a recombinant brain natriuretic peptide. So obviously there is going to be natriuresis, there is going to be diuresis, plus this drug also produces vasodilatation, and in fact it reduces the ventricular filling like glyceryl trinitrate. That means it has a very prominent venodilatation. So in the process the edema is reduced and symptomatic benefit is seen with Nesiritide. Like the previous drugs, Nesiritide is also indicated in refractory cases of highly symptomatic patients. This is the injectable form of Nesiritide. Tolvaptan is a vasopressin receptor antagonist, and as a result of this there is going to be diuresis and hence symptomatic relief, indicated in refractory cases of severely decompensated patients. It has also been indicated in syndrome of inappropriate diuretic hormone secretion. Tolvaptan given as tablets. Now there is a drug called Ivabradine. Ivabradine is a pure bradycardia producing anti-angina drug. That means Ivabradine, unlike beta blockers, does not reduce myocardial contractility. It only reduces the heart rate. Now Ivabradine is indicated in stable heart failure patients class 2, class 3 and class 4. Now how does this drug reduce the heart rate? It hyperpolarizes the sinoatrial nodal cells, and in the process it improves ventricular filling. Now Ivabradine is used as a substitute to beta blockers when beta blockers are contraindicated or when the heart rate does not reduce to less than 75 per minute with beta blockers. That is, adequate response is not seen towards beta blockers. So it is used along with ACE inhibitors plus aldosterone antagonists. However, the cardioprotective effect which is provided by beta blockers is not seen with Ivabradine. Ivabradine tablets. Now I told you there are two combinations, fixed drug combinations which are used in heart failure patients. The first of it is a combination of hydralazine and isosorbide dinitrate. Hydralazine arteriolar dilator, isosorbide dinitrate is a venodilator. So this combination is indicated in patients who do not tolerate ACE inhibitors and ARBs. That means if a patient is having any contraindication to ACE inhibitors and ARBs like renal artery stenosis, renal insufficiency, reduced blood flow to the kidneys, then I can use a combination of hydralazine and isosorbide dinitrate to provide symptomatic and survival benefit in such patients. However, the efficacy is much less with this combination when compared to ACE inhibitors and ARBs. So this is the fixed dose combination of hydralazine and isosorbide dinitrate, which is used as a substitute to ACE inhibitors and ARBs. The second fixed drug combination of sacubitril and valsartan is also indicated in heart failure patients, and this combination has been found to be as efficacious as enalapril. That means it can provide survival benefit as well as symptomatic benefit. Now, sacubitril is a neprilysin inhibitor. Atrial natriuretic peptide, brain natriuretic peptide, and vasodilator peptides are substrates for neprilysin, and when neprilysin is inhibited, all these substances will accumulate, giving rise to natriuresis, diuresis, and vasodilatation. And this combination has been found to reduce mortality as well as morbidity. Morbidity in the sense decompensation and hospitalization is also reduced in heart failure patients. So this is the fixed dose combination of sacubitril and valsartan, and this combination has found to be as good as enalapril in patients of heart failure in clinical trials. Dear students, I come to the end of this presentation. As you see, there are so many drugs which are used in the pharmacotherapy of heart failure. There is bound to be confusion, and we can overcome this confusion by repeated readings. And yes, if you have any doubts, feel free to ask. Thank you very much.